Bob. That was a great introduction. Yeah, actually my undergraduate major at Edinburgh was Geographic and Economic Change in Scotland, 1580 to 1830, which is incredibly useful. But yeah, I'm a professional futurist. My definition of a futurist is an economist who couldn't handle the calculus, basically, in the sweeping generalization business. But I did grow up in Scotland and then moved to Canada in the late 70s. My connection to healthcare and to healthcare IT was that even though I was qualified as an urban planner, I never actually practiced as such, and got hired by a management consulting group that worked for all the teaching hospitals in Vancouver, British Columbia, and it was Management Engineering Unit 13.1, which is the Canadian healthcare equivalent of the KGB, basically. But anyway, you know, I was doing sort of clinical re-engineering before it was fashionable, and actually wrote the justification for an all-computerized university hospital at UBC in 1979. You know, they were trying to get money for a Meditech system, and that was, you know, if you do the math, over 30 years ago, and it's kind of pathetic that this is as far as we've come, you know, in 30 years. But we'll come back to that in a second. Now, I'm sort of trying to set the stage here for you in terms of a lot of the things you're going to hear about over the next couple of days, and talk a little bit about where we're headed as a nation with regard to healthcare. And the title I've taken is The Future of the Healthcare Marketplace, because it is a marketplace, even though government pays about half of it. It still behaves somewhat like a market. But the other subtitle is important: Life in the Gap, Life in the Game, because we're in this weird period of time now, between now and 2014, where the main provisions of health reform really haven't taken place yet. The big news happens in 2014. But there's this little thing called an election between now and then, which could alter the course of it entirely. And so we're in this kind of weird situation where we're applying for one future, which may change radically. And I want to kind of cover both the direction of that and the factors that to watch for going forward. So there's a number of things I want to point to. One is this notion of the second curve. Now, I wrote this book, The Second Curve, about 15 years ago, and I've used it a lot with different groups in many industries and in many countries, actually, but it's become strangely relevant again for healthcare, and I'll explain why I say that in a second. I want to say a little bit about the future of the economy, because I believe it's very important for healthcare in two dimensions. The economy will determine who wins the next election. If it's going really badly in the middle of next year, then the president has no chance, in my view, of being re-elected. If it's going reasonably well and we have a sense of upbeat view, even if unemployment is still relatively high, then I think there's a good chance he gets re-elected. The other reason the economy is important is it will determine who exactly in the future has good health insurance. Because most of you in the provider side are dependent on commercial health insurance for your entire margin. And so who has good commercial health insurance, private health insurance, matters a lot to the economics of your institution. I want to say a little bit about value in healthcare, because I think that's the struggle that we're all really trying to get to, not only in this country, but all around the world. So let me just briefly say something about the second curve, because and you may quickly get the relevance of this. This is an embarrassingly simple notion. The argument is that most businesses in most industries are going along quite nicely on the first curve. It's the business they know how to operate on a daily basis. It's where they get all their profit and revenue. But they have a sneaking suspicion in their gut that it's going to decline in absolute or relative terms. Now, that red line coming down might not be revenues, it might be growth rates or margin over time, and be replaced by a second curve, a new business or a new way of doing business that is radically different from the first. Now, the dirty little secret of futurism is we cannot actually predict the future. You know, I ran a group called the Institute for the Future that was founded in the late 60s by a bunch of pointy-headed mathematicians from the RAND organization who actually did think we could predict the future, and they, you know, over the years we kind of figured out that was impossible. But one thing we did learn was that there's a natural human tendency to overestimate the impact of phenomena in the short run and underestimate it in the long run. So you commit two types of errors. You walk away prematurely from that first curve where all the money is, and you may be walking away from 4, 5, 10 years of profitable growth. Conversely, if you don't start building that second curve, you may not be around later on in the 21st century. So that's my talk. Thanks a lot. Okay. So when the market tanked in 2007, I spent a lot of time trying to analyze what went on and came up with my distillation of how the global economy worked up until 2007 in 10 easy steps. And it goes like this: hardworking people in communist countries like China and Vietnam made good, cheap products and exported them to America at a profit. They saved as much money as they could. The savings rate in Asia, as you know, is between 30 and 50%, depending on the country. Our savings rate in America prior to the meltdown was zero, absolutely nada. The Chinese loaned their money to US banks and government, and our banks, in their infinite wisdom, leveraged the money 30 to 1 and loaned it to Americans to buy big houses we couldn't really afford. Many Americans and a lot of immigrants were fully employed building these houses, cleaning them, selling mortgages and title insurance. Some Americans worked as nurses, doctors, teachers, waiters, or cooks because they weren't any good at real estate or construction. And the rest of Americans were prison guards or gave PowerPoint presentations to each other. As we say in Glasgow, half joking, full serious. I mean, this is exactly how the economy worked. We all had jobs, we all could borrow money to buy stocks and more houses, and there was great demand, so the value of the houses and the stocks kept going up. Because we all felt rich, we got to borrow even more money, so that we filled our houses with good, cheap products made by hardworking people in communist countries. Now, it is exactly how the economy worked, and that economy is over. Despite the valiant efforts of the Obama administration to reflate it, it's going to take a long time when you've got, by any estimate, 10, 11, 12, 14 million people underwater in their mortgages. It will take a while for that to be buoyant again, and home sales and so forth are plummeted. And we in healthcare like to say, well, we're kind of immune to all of that. Well, not really. I mean, the economic meltdown did impact healthcare. 7 million people lost employment-based health insurance in 2009 alone. We currently have 50 million uninsured. That's like a large European country. You know, in fact, if the uninsured got together, they could be in the G20, for God's sake. I mean, it's ridiculous. We've also seen the fact that people can't afford the down payment for medical care, and that's one of the reasons why most hospitals have seen a slowing in demand, particularly for elective surgery over the last year or two. And obviously the credit crunch impacted a number of institutions. It was easy credit for healthcare 5 years ago. It's not so easy today, although things have gotten better, and certainly since the depths of despair of March 2009. But yet, despite all that turmoil, healthcare keeps chugging along and growing. I mean, it added 500,000 jobs from 2009 to 2011. The question for the next economy is whether or not that's going to be kind to healthcare. And the reason I say that is, obviously, we've got this mega issue of all the math-based jobs moving to China. But more importantly, perhaps, for healthcare is the fact that we suddenly decided school teachers and firefighters are the bad guys, right? And this is not just true in the US, this is true in Europe also right now, and that their rich health benefits and pensions are coming under assault. And that's a bit of a problem for healthcare, because the people in America with the best health benefits are school teachers and firefighters. And that is the core, if you like, of demand for much healthcare, and they're the people with the best commercial health insurance. And I also think we need to change the compensation principle, even at the micro level, and I'm happy to talk about some of that in Q&A. So what's going on out there in terms of hospital systems? You hear a lot about accountable care. I don't think the CMS Shared Savings Program is going to be the big smash that we all thought it might be. But make no mistake, accountable care is the megatrend. And by that, I mean people who are building systems with a lot of different assets, preparing themselves to accept broader risk, financial risk, for the management of populations, for value, not volume. And that's going on all over the country, and you may work for many of these folk. The only thing that's sort of alarming is people are making investments for growth that I find kind of astonishing. And just to go to the data here, we surveyed hospital leaders and found, 2/3 of them are opening satellite patient care facilities. 2/3 of them almost are buying doctor practices. 48% are adding surgical capacity. It's a bit like commercial real estate. They all think they're going to win, right? And I think they need to have a little reality check there. The good news for all of you is 85% are investing in HIT, obviously in pursuit of meaningful use. This point about merging with doctors is a huge challenge for all of you IT professionals, because part of the impetus to join with these larger systems is for the practices to avail themselves of the capital of the hospitals in installing this stuff. And a lot of doctors who have been purchased are sort of passively aggressively being purchased. They're not exactly running with open arms to work for some elsewhere. And of course, the groups they're looking for are primary care and cardiology. So I think we're in a healthcare delivery system in transition. In the short run, there's a lot of winners out there who have done some good work and have got cash in the bank. We're seeing tremendous amounts of consolidation. For those of you in the vendor community, we're seeing tremendous consolidation, which means fewer customers who are more powerful going forwards, and I think that's a reality you have to prepare for. But I actually am very, very, very encouraged. I think this is the best time to be in healthcare. As I say, I've been to a lot of markets, I work with a lot of different groups, and I see over and over and over again in every market I go to, leaders who are committed to building, not necessarily an ACO for the CMS pilot, but are building systems of care that are focused on broadening the financial risk envelope that they look after for the care of patients. Some of it is being forced by bundled payment and Medicare incentives, but a lot of it is because people are recognizing that that's where the money is and that's the right thing to do for patients. They're integrating with their medical staffs, they're dedicating it to higher performance, they're having ubiquitous, non-negotiable performance measurement and management across the continuum of care. And none of this can be done without integrated HIT solutions. You are at the absolute epicenter of the necessary care redesign going forward. And when people say to me, well, how do we get the business model to get from here to there, from the first curve to the second curve? I say, make it better, faster, cheaper. And if you do that, you'll be in the phone book. No matter what scenario, no matter who's running the country, it doesn't matter who's in Congress, what the crazy people in Washington do. If you can deliver higher performance, take costs out, improve quality, you're going to be around. And you can always flip the switch on the business model to whatever is the prevailing idea du jour at the time. So in closing, I'd just say the economy is creating wealth, not jobs, which is a bit of a problem. Health reform will be decided by the 2012 election, and jobs will play a part of it, but it won't be the total determinant. And no matter what, we have a system that has got to get affordability at the top of the priority scale, and I think we're starting to do that. And that requires changing the way we do what we do. And I would just say that, meaningful use should drive meaningful use, right? I mean, the incentives. Unfortunately, there's a lot of meaningless use out there right now where people are spinning their wheels. But I think we will get there, and I think it's important to manage expectations in the short run and hold out the promise of Kaiser in the long run, that you can transform systems to deliver on a number of different dimensions, most notably chronic care management, which is where the big need is, prevention of inappropriate readmissions, of using registries and disease registries to manage highly comorbid patients, to deploy evidence-based best practices, and to customize genomic medicine for the future if you take the long-run view. And I believe we're doing all of that, and I think you are the leaders who will make that happen. And by the way, if you all don't do it, I know Google went away, but somebody else is going to pop up to help us do this. Maybe it's Walmart, who knows. But in the future, I think we will have the best health system in the world. We don't right now, but we will, because we've got a lot of smart people, we've got a lot of good leaders, and we've got a commitment, I think now, amongst those leaders to actually try and improve the performance of American healthcare. HIT is a big part of that, so I salute you for your work, and I'm happy to take a few questions before we adjourn to the bar. Thank you very much.